Okay, now, I know it's hard for some of you. Medyo mahirap, pero I think for a moment, try to imagine that you're like a general practitioner. Let's say 1920s or 1930s. Or if it's that difficult, just think of someone in the community, the family doctor. When I say family doctor or general practitioner or the doctor of the community or your personal doctor, and you live somewhere in the province or in a rural area of a developed country like the United States or Canada, think that. Okay, so you're the family doctor or personal doctor or neighborhood doctor, community doctor, general practitioner, and you're the medicine of your time. Like majority of the population actually go to you, not unless you live in like a major city where there's this newly built during the 1940s, 50s, and so that actually they started earlier than that, but the numbers are increasing. Those big medical centers. If you're sick, you don't directly go to those places. Well, for one thing, you don't just walk in there, and for another, if you enter those places, especially nowadays when things are becoming more and more expensive, walking into that ambulatory care facility or emergency room will probably cost you like at least 1 month or a couple of months worth of salary. So you really don't want to go there, and for a lot, you really don't want to, even if it doesn't cost so much, because you have no idea or you don't know the people inside there, and you have this doctor who's been taking care of you ever since you were a kid, or has been taking care of your child ever since your child was born, took care of your mom. This doctor really knows you, knows how much funds you have available for medicine, knows exactly how you're reacting, can really talk to you, and knows how to talk to you in a way that you can really understand and make sense out of the increasingly complicated medical terms or jargon. And so it's like part of the family, part of the community kind of personal doctor. Now, so 1920s and to 1930s, you start having academic medicine. They started becoming more structured, and they started separating into different kinds of fields. First, you have doctors taking care of the adults, and then some doctors said, well, kids are different and we do different things. We give immunizations and you don't do a lot of those things for adults. So we kind of should separate and focus our research and our practice on kids. And then, of course, later on, you also have the elderly will be different. They have other issues. We should be screening for stuff. And so you have geriatrics, and it just got sliced into little bits of specialists or subspecialists or super specialists. So you have a surgeon for the kidney, and then a surgeon for the brain, and you have a surgeon for a particular diseases of the heart, particular disease of the brain. It just got sliced up. Right? You have a clinician for the lung, for particular disease of the lung, for particular kinds of this disease, super specialists, and things like that. Now, you're this general practitioner and looking at all these developments, and it looks like people are pouring in all sorts of effort into those little specialty stuff. And of course, one of the reasons is it's the 1940s, 1950s, 1960s. If you watch the shows there, people seem to think that everything can be solved with science. In the 1960s, where they were able to go to the moon, so we should be able to fix everything with enough technology and science. So they kept on pouring funds and money and effort and time to these things. Now, of course, if you want to do science, the thing about science is you have to simplify matters, at least at first, and for several decades, so that you'll be able to better control the situation and do your research and study, which is well and good because they came up with all sorts of procedures and drugs and herbs and medications. But they're saying, well, you do that to try to figure out what you can do, but ultimately, later on, you're actually taking care of real complex people. The person in front of you is not just a lab rat, or it's not sample number 32 or 33 in a randomized clinical trial. It's an actual person, and you know this person. This person is very unique. This person grew up, and you took care of this person's mom, and has very important life circumstances, and lives in a particular community that you're also aware of, because usually general practitioners and personal doctors and family doctors actually live in the same place as their patients. You have the clinic there, and they go to you, or you go to their houses. That's pretty much how it works. And you're saying, things can be kept simple so that you can do all your clinical researches in these big centers, but ultimately you have to bring it back to reality. And of course, the question is, we might not be able to learn anything if we make it more complex. And now the answer of these generalists as opposed to specialists is, well, no. You learn a lot of things. You don't just give the drug to sample number one. You give the drug to the person you actually know. You can advise the patient better, or this person better. You can help the family help this person better because you know them perfectly well. So the application of all the stuff you've learned through science should be brought back to a personal level. And you're actually working in the community. You know the problems of the community. Let's say you're in a community where there's like 2 big factories, and you're looking at medical conditions or health conditions which are related to those factories, or you're looking at this place with particular habits or ways of doing things. And then maybe the men during the weekends would go with their buddies and drink in this particular place in this small village of yours. You know exactly how things work. And you don't just say, well, we do science for all men. We know what to do with all of them. But you'll be pretty effective, or you'll be more effective if you actually consider this particular person in this particular village living with this particular family, and tailor your advice and your management and your monitoring of this person based on all those knowledge, which is not going to come from your clinical randomized trial. So that's pretty much it. So why am I telling you that? I'm telling you that because when we look at diseases during your first few years of medical school, you think based on what we teach you and based on what is popular nowadays. You think biology. You think there's something wrong with a cell. You're thinking nowadays you're thinking like genes, and you're thinking about RNA or DNA, especially with the pandemic and all. You're thinking about chemicals to treat the patient. You're thinking of gadgets to monitor the blood pressure, and you're thinking about numbers and technology. Or you're thinking about what you need to cut and how to cut it, and how to repair it, how to tie things together if you're like a surgeon, or how to use a microscope to kind of cut or piece things together. That's pretty much what you're thinking. And so it's like pathology, biochemistry, biology, and everything else. But there's another way of thinking about disease. The generalists are saying, you should also pay attention to the other ways of thinking, because they really count. It's not nice technical science, but they still count. It's not very popular during their time, like 1960s, and it's not very technological, quote unquote, but it's very important. So you think about the person. The person gets sick, he's scared, and then you are telling this person that they need to do this as far as your science is concerned. And you pretty much know what's happening to this person, the way he's reacting. You know what the family condition is. You know how to mobilize the family so that they can help out this particular dad who's the breadwinner, or this mom who's sick, or a grandma. And of course you need that. You don't just give the drug and you, the family, just deal with it. That's not my problem. You don't say that. You're part doctor and part family. That's why they call you a personal doctor. So you put those things into the management process. So what are we describing? We're describing the psychosocial experience of the disease, otherwise known as the illness experience. So that's one way of looking at the disease. Now, for your particular department in this hospital in Manila, that would be like 1/4 or 1/3 of the consultants in your department, they're interested in the psychosocial, emotional reactions to the disease, and some of them would be interested in the individual psychosocial and emotional factors and how you should take care of it so that you can take care of the patient better, and some of them would be interested in the family relational factors and the emotional factors and the interplay among the members of the family or the close friends and relatives of this particular patient. Of course, those things count. When you actually do something, you don't just write the prescription and, that's his or her problem, and, whether he gets family support or support from his close relations, that's not your problem. You don't say that, right? Now, the generalist or the family doctor or the personal doctor in the community would certainly say, you don't do that. I mean, science says we don't know what to do with those, but just because the science is just focused on the micro, like the artery of the heart and the drug working on the liver, and you give it to like 100 people and it will work for. Those are the, even if that's the knowledge base, you're actually taking care of a real life person. So you don't just think non-entity, non-person. You think of actual person. And people, the reason why they're called people is because they have emotions. They're unique individuals and they help each other out. They live together. They have families. And if you mobilize these things, whatever your science has come up with or whatever you got out of science, you'll be able to apply better, and you can be able to pick and choose which one is most appropriate, right? So now the other way of looking at it is, well, you live in the community, so what else would enter your head? Well, you say, well, the people in those big medical research centers, they have no idea. They're just there in the big city, like 4 hours away. But I'm here and I know where they live. I know the air in this place. I know where they get their food. I know what people like eating here, and I know if they can actually jog around the place, or there's a better way of exercising instead of just running along the expressway, which you shouldn't be doing. You're asking for more trouble. So, and the hobbies of the people there, and you know what the park looks like. You know how important spirituality is. You know the resources of the community. Those things count. You'll be a better carer for health if you put those things into consideration. You know the income level of everyone in the community. You know the sources of support. If it's low resource patients, families, and low resource communities, you know the kind of family-based management or community-based management that would be appropriate for that community. You don't just say, well, those smart expert people in the United States, they looked at their trials and they come up with this paper, and we want to be as scientific as them. We'll just swallow everything they said in their entirety, and it's not our problem if the family or the community cannot afford it, or if it's not realistic there. Maybe I should just practice in a very affluent, rich area in our country. You don't say that, right? So that doesn't make sense. If you want to do that, just go to that developed country and practice there, or if you want to do that, just stay in a very affluent place and practice there. But of course the question is, what about the rest of the population? It doesn't make sense. Real science or real evidence-based practice doesn't just use evidence coming out of the micro researches coming from elsewhere. It uses, more importantly, the evidence coming out of the actual person, out of the life situation and the condition of the actual person in front of you, his family, and the actual people around that person and the community. That's also even more important information. That's part of the evidence, as part of information you should be using. So don't just open a journal coming from the UK or from Germany and said, they think it's good if they paid for the drug and they gave the medication free drug and improved their condition, or out of 700 people we treat, 10 will work, and it has a p-value of this, and therefore we should do it in our community, right in the middle of the province, with an income level that's like 10% or 5% of the income level of that country who just wrote about that clinical evidence or clinical. It doesn't work. So what am I saying? The community perspective, the village, people in the community, people in the village, people in the town perspective, the population perspective, the culture and the habits of those people, the resources available that's really there in the community also count, and they're very important. That's another way of looking at disease or the disease experience. So this is not disease in terms of pathology or biochemistry. Those are other subjects. They're actually bigger subjects. Like you study them for like entire semesters. This is just one lecture. But the family doctors or the general medicine people, of course, I'm part of them. This is how they wanted to view things. Now, wanted past tense, because this way of looking at things is becoming less and less popular nowadays, right? So it's becoming, unfortunately, it's becoming more and more commercialized. You go in the clinic, and the clinic has to survive because the electricity is expensive. You have to pay for your personnel, and the way things are set up right now, the very commercialized approach or system of medicine thinks that all you're good for is like 5 to 7 minutes worth of visit. Like, why spend so much time dealing with emotions or psychosocial, or if somebody has a heart problem, why deal with the person's fears and mobilize the family and think about the community, when all you need to do is prescribe certain medications and make that patient buy and pay for those medications. And every 6 to 12 months, you have a new, much improved, so-called more expensive medication. And then, the representative from the people who made those medications will come to your clinic and tell you, you should look at this article. It's much more expensive. No, I mean, it's much more effective, or so they say. I mean, really, it's effective if you give it for free and the person can actually swallow it every day. But if it's that expensive, in real life, you pay for those things. They're not free. They're only free during research or clinical trials. But in real life, if the patient has to sacrifice medication money for food and healthy habits just to buy that drug, it probably doesn't even make sense. And of course, the representative of that company might even say, well, since you're doing such a good job and we're seeing that you're giving the more effective medication, and we saw how much prescriptions you're writing, do you want to travel abroad, or isn't there a nice 5-star hotel conference that you want us to help you with? That's the problem, actually. It doesn't look like it's going to get solved anytime soon. Anyway, so that's really it. So if from a population standpoint, one way of looking at it would be using the ideas of epidemiology, and what we're using here for this particular session would be the introductory articles coming out of the United States Centers for Disease Control, CDC, and this is like an introductory article or modules on epidemiology. So you're thinking at least the basic ideas. You're in the community, you have like charts of 1,500 to 2,500 patients. During residency, I think beginning first year, they gave us about 200 to 300. Some of us got 400, depending on the clinic, how big the clinic is. Patient charts, meaning actual people. Some of them are from families, some of them are individual patients. And then by the time we graduate, after 3 years, most of us would have like 2,000 to 2,500 charts. So you're looking at really a small community. I mean, you're actually taking care of people you're taking care of who would comprise like a big chunk of the community, or it's like taking care of a small population. So you're thinking, especially if you actually live in a community of like 2,000 or maybe 10,000, that's like 1/4 of everyone. So you're thinking, well, if I'm going to do some screening tests, looking for people who have cancer but they don't know it yet, so maybe I should call that subclinical, because we don't know that they have it. So they're not labeled as having cancer yet. Nobody knows. So as far as we're concerned, they're out there, but we don't know. So that would be your cancer screening test. That would be your mammogram, pap smear, and such. So I would want to know how many people are those, right? So now if you're thinking of people who don't have the disease, and you're thinking, well, if I vaccinate them or give them this vaccine early, then maybe they won't get it. That would be your preventive stuff. So that would be, and then you want to figure out how many people are actually exposed to the thing that you're trying to fight against. So that would be like the people who are susceptible in the community. Maybe for this particular kinds of prevention, I should focus on them. And then you're thinking, how about for this particular disease, the people who I'm treating or who are actually sick, getting treatment, getting medications or whatnot, or rehabilitation, to try to see how far they can go in terms of improving and cure. That would be the actual big chunk of everybody's concern nowadays. That would be the clinical care or the clinical manifested disease, the people who actually have the disease as far as we know. And then the people who actually ended up with a particular outcome. Or you might be thinking, who are the people walking around with the virus without knowing that they have it and without feeling that they are sick, and they can pass it on to someone? Then that would be someone who carries the virus. So let's call it the carrier state, right? Or someone who got exposed to the virus so that he doesn't know that they're sick yet. So that's subclinical. So we can put labels on different populations. So that's one way of looking at groups. And why do you look at things that way? Because, you're looking at all these 2,000, 2,500, or maybe 4,000 if you really have a big practice. I mean, I know some old general doctors have like clinics containing 5,000 to even 10,000 charts if nobody wants to stay there except for this particular doctor. So you're thinking that. So what should I be doing for a whole bunch of people? And that's one way of looking at it, using the ideas of epidemiology. That's actually the natural history of disease. That's what it's called. Now, the other way of looking at it from a different perspective would be, you're not just looking at charts and people's names. You actually know these people, right? So you actually know these people, and you're taking care of them, and now they're sick. And this particular person, you knew him from childhood, and then you know his father, and you took care of his father. You actually helped his father get into the big hospital when he needed to get admitted, like 2 years ago. This big medical center, like uptown, like about 3 hours away. And so this particular person. The thing coming out of the book, which says you should consider 1, 2, 3, and 4 kinds of interventions or medications or surgeries or whatnot to help this person with the disease. But then you have to pick and choose which one would be appropriate, or you have to factor in this person's resources, and you have to factor in other things that might be making the disease worse, right? Stress can actually make a lot of diseases worse. We don't think about it because, it's just a lot easier to just prescribe the medication. But sometimes if you take care of the stress and the lifestyle stuff that makes the disease worse, you're actually doing a much more effective job, right? So now the market-oriented way of doing medicine is not too interested in that. Like, what can you earn, or how much product can you sell if the doctor spends 50% or more of his time just helping the patient fix his lifestyle? Not much, right? So now you create a system that only allows doctors to see patients every 7 to 12 minutes. Then even the doctor who wants to do those things won't be able to do it, which is unfortunate, and which is pretty much what's happening right now in market-oriented developed countries, Western countries, or countries trying to be westernized for some reason. They think it's good. Anyway, so that's what you're looking at. So what is that? So that would be the biopsychosocial, or the psychosocial way of looking at the disease experience, the illness experience, right? So that will be different. So you're not thinking people with disease, people without disease, people who might get exposed. You're thinking of, what if this person starts experiencing the disease? So how does it affect him, or how does it affect his family? how should you approach this person? Aside from all the stuff coming out of your medical textbook, how do you apply that to this particular person? How would the family react? How does this impact the family? This particular real life family right in front of you, living in the same community you're in, and you know this family. So how do you do that? What about this person who is actually getting worse with a disease that's getting worse, or experiencing a crisis, like got hospitalized, got a heart attack? What else should you be doing aside from thinking about drugs and procedures? And you're actually talking to real people. You're not just prescribing stuff on someone who doesn't react to anything, right? I mean, this is not subject number 32, 33. This is like real person. This person reacting emotionally, person with a family kind of person, right? Well, of course, this person, once this person gets discharged from the hospital, he lives in his house with his family members who's going to help him out, who's reacting to whatever he's feeling, but they're also in the community, and maybe they can access a whole bunch of psychosocial support, or even financial support to relieve the financial burden or the stress coming out of the very expensive stuff that they think they need to do to keep this person alive. Now, of course, in reality, a lot of if you actually look at the data or the information, a lot of the stuff they sacrifice half of their family income on doesn't help that much. I mean, it helps based on the trial if you do the statistics, but if you really think about it, you're causing more harm than good by insisting on these fairly expensive interventions. And unfortunately, that's one perspective nobody really pays attention to, right? So personal doctors, looking at what's happening in the big cities, things are becoming too hyper technical and scientific and, cookbook oriented and commercialized even, are saying there's something wrong with how things are turning out to be. And they might say, well, we should not forget that there's another way of looking at things. And that is what this module, this session is all about. So don't think biology or pathology, because you'll get confused. Like, things will come out of that mindset which won't make sense. Like, for example, well, what if they have symptoms like a little cough, or what if they actually have the disease, you don't just know it yet? So what do you call that? Is that like, what if it's just that nobody looked? That's the wrong question. You're like population based, and this model is meant for this particular thing. As far as as far as everyone knows, is this person labeled sick or not? Now, what are you after? The people walking around who are sick or who have the cancer, but they don't know it yet. So why are you thinking that? Because you're thinking of cancer screening tests. So it's the models. Models are meant for particular things, and models are not meant to be models for other things. Like, if you're thinking biochemistry, or you're thinking bio-organ-based type pathology kind of thing, you don't use the models coming out of family psychology or psychosocial models, or you don't use community-based, population-based epidemiology kind of models. You use something else, right? You look at things from some other perspective, right? So don't get confused, because it happens. Like, it always comes up, like, what if this person, if you look through you do a scope and you see that, so you're wrong, it's not actually, he actually has the disease, we thought he doesn't, so that's the wrong classification. So what about that? Well, the answer is that's the wrong question, right? So stop thinking that for now. Those are different subjects. So this is another way of looking at it, and you should pay attention to this one, because you only get one session out of the entire 1 or 2 years worth, and then suddenly you're back to chemicals and organs and pathology and cells and DNA and stuff. But don't forget, they're real people living with real people in their family, reacting, and they actually live in a community, and you're familiar with that, because you're the generalist, you're the family doctor, personal doctor, the doctor of the village kind of person, and they know you're part of the church, and you might even part of the, like, in the neighborhood, like 2 blocks away from their house, you can actually go there. You know their kids, you might even be the godparent of 1 or 2 of their kids, and so you're the real, true to life personal doctor. You're not moving around in some huge building somewhere in the city with lots of gadgets and machines. If you're really sick, and you're the patient, you might end up there. But it's better to handle things through the doctor on the ground. So there you have it. So that's one way of looking at this session, or that's one way of approaching or getting oriented with the topics that we're going to talk about. Okay.